Okay, this is an on-time group.
Mhm.
All these HEDIS and risk adjustment people, you're good at managing the details. Okay. Well, this looks like a pretty good group to get started with. Kristen and Izzy, if you guys just want to manage anybody else that comes on, I'll start and I'll leave it up to everybody else to join in as they dial in.
Will do.
So thanks everybody for joining. If I don't know you already, my name's Kesley Crichton. I'm the Chief Sales Officer for BeneLynk. We're joined by your account managers and our special guest and quality SME guru, all those things that I just love about her, Melissa Newton-Smith. She's going to be the star of the show, but I'm going to do a quick introduction here in the beginning. You're on mute by choice. I want to encourage you all to come off of mute and join in. Stay on mute if you have background noise or if you're driving down the road in Michigan or wherever you might be. But other than that, please participate, and we want to hear your suggestions. You can raise your little virtual hand or just blurt out if you got a comment or a question. So it's not overly formal here this morning. So because there's so many more people registered, I'm not sure if everybody's going to join. I put up the logos for everybody that's registered on this opening screen because it will take a little bit too long for everybody to introduce themselves. Otherwise, I do ask if you do have a question or a comment, though, that you start by introducing yourself, where you're from, and your title or just what kind of department you're in. If it's risk adjustment, quality, social determinants of health, and kind of what your main focus is at work. So we got a lot on the plate today, so I'm going to dive in. I'm not going to spend a lot of time on the commercial part of this, but I did want to kind of put up this slide and this is something that we hear from so many of you kind of repeatedly. So I wanted to put this up as kind of the purpose of today, right? So many of you tell us over and over again that we are the easiest vendor to work with, that we are extremely transparent and flexible and innovative. And that's really what I want the purpose of today to be, right? So we try to maintain that all the time, but we also like to try new things. And we really need you guys, our customers, to go along on that path with us. And so in order to, learn from each other today, to share ideas, I tried to make sure that we didn't invite anybody that was really competing in a lot of areas. And that you were open and felt comfortable sharing ideas. We also want your suggestions. So if we're doing something that we can improve BeneLynk, or if you're looking for us to do more or create other services or help you in any other way, we'd love to hear those ideas as well. I focused just on Medicare Advantage today. So this is the suite of services that we offer. It's really focused around social care. This is all we do. And so for those of you that I've known in my past history of Altegra Health and Change Healthcare, where we started getting really wide, we're not really looking to get beyond social care. We really want to stay with our passion and what we are good at, and that is helping people overcome challenges in their life related to their social risk factors through a variety of different ways. Part of that is identifying veterans and veterans using VA healthcare. All of these services can stand alone. It can be an a la carte menu, but we really think there's a lot of efficiencies for some of our clients when we combine them. There's efficiency for the member, but there's also efficiency for you to make sure that we're improving your outcomes for both risk adjusted revenue, quality performance, that overall intuitively, we know when we start identifying and solving for these challenges with your members that we're going to bend that cost curve and that we're going to improve the member experience, because there's something in here for everybody. And we just want to make sure that we help you know your members as well as you possibly can so that you can deliver the best healthcare services to them. And when you think about how we put all these services together, this is what we think. You start at the top by having a personal human-to-human conversation using our live advocates. We were almost up to 526 states now all across the country, and asking them what their needs are. And that can be a really informal conversation, or it can be more structured so that we can start talking about meeting some HEDIS measures like SNSE. But when we start that we ask them also if they're a veteran, if they're using VA healthcare, what that's like for them. And as the conversation continues, you can build up trust and credibility and validity with our services. We can also identify identify those members that are financially insecure and help them to receive benefits that are a little bit more detailed when it comes to Medicaid, Medicare savings programs, SNAP, or helping them keep those benefits. And I know you're all here because of BeneLynk today. So I just wanted you to understand kind of where BeneLynk fits in our overall services and as a social care program. And we really think that it is a social determinant of health. These folks grew up accessing care differently than those that aren't a veteran. And so understanding that care is really key. And so we wanted to really understand more. I get risk adjustment. You all on the quality side, I think that's just a lot to get your head around, and it changes every day. So we went and contracted with HealthMine and with Melissa Smith because, you know, she knows this stuff so much better than I ever will. And so they did a deep dive into our medical records and into our services. And so I'm going to ask her to kind of take the ball from here and talk about what they learned when they looked at all of this. So
Sure.
Thank you, Melissa. Introduce yourself.
Awesome. Thanks, Kesley. You're so kind. I don't know if I could be so kind to myself. I am a self-proclaimed guru extraordinaire of minutia within the HEDIS, the quality, the Medicare Advantage space. For those of you all who don't know me, I do lead an expert boutique consulting practice of similar like-minded Medicare Advantage experts across all domains that matter in the work we do. So we've got operations SMEs, pharmacy SMEs, HEDIS SMEs, clinicians, and then of course a few of us that are true stars geeks, as I like to say it publicly. So a little bit like Kesley said, Kesley and her team called us and basically asked us to come in and take a look at all their programs and kind of give them the tips and tricks of how might they port all the great work they do now to all of the new needs of stars, the new needs of Medicare Advantage, because they are changing. And that's kind of what we want to talk about today, is the veteran element of this. So Kesley, are you okay if I take a little spin through our couple slides and then we'll kind of, you can pop in and, okay, good. All right, so Kesley has been honest that we're a user group and we're to keep this good and chatty. So y'all weigh in. I've got my eyes on the chat functionality, and we'll stop any time that's convenient for y'all. We'll stop and chat. So let's reset the stage for just a minute about what we're doing with veterans. So a lot of you guys know, before I got into the expert consulting space, I actually was a health plan star leader for a while on the Part C star side, for a while on the Part D star side, and then across the entirety of the human experience that drives our star rating. That's interesting, but from this call, what makes it fascinating is that while I was at Cigna, they actually put in 2 veterans to lead our stars charge from the executive level, 2 different branches of the military, both veterans, both acclimated to how the veteran uses the combination of our private insurance and their benefit from having served our nation. And that's an important bifurcation, because our veteran community loves their VA benefits and are very wed to them. Now, what we've generally done in Medicare Advantage with the veterans' presence are one of 2 primary activities. One, as you guys know that have worked with Kesley and Sean and your account teams, we've done a great job through BeneLynk as the primary and often only source nationally of grabbing that veterans chart and mining it for risk adjustable details that are compliant and legal and safe. So we've managed to capture the top line risk adjusted revenue. We've also generally done a second activity through BeneLynk as the primary and often only source, which is when we get to the HEDIS data capture for hybrid HEDIS measures, we've often found non-compliant members who happen to be veterans in our sample of 411 hybrid records. And we've called Kesley or your account reps and said, hey, I got this list of non-compliant members in my samples of 411. Could you grab the VA charts and let's try to find the missing gap in their VA records? That's worked really well for all of us on the line that are Medicare Advantage hyper-focused until now. And now we're in a new place. we're in a new place heading into 2024 where NCQA and CMS are changing the paradigm of how we behave. They're expecting us in our voluntary participation in Medicare Advantage to do two things new that we believe BeneLynk's veteran services can support well. CMS and NCQA are expecting us to measure and assess the entire quality performance for all members. They're moving away from the hybrid HEDIS measurement methodologies to holding us accountable for all HEDIS measures for all members. They've put a timeline of no more than 5 years to have that finished. So you can imagine where we've been pinging Kesley and the team for little bits and pieces of VA charts for those few members in the hybrid samples of 411. Now we're going to have to get all of the VA data for all of the HEDIS measures. There's robust opportunity there. CMS is also holding us fully accountable beginning in 2024 for outcomes. Literally patient-reported outcomes measured by the Health Outcomes Survey, which they love in Medicare. This is going to require us to harvest more intel out of the VA side of the house about our patients' trajectory, their actual social determinants of health, their actual personal barriers and challenges and mental health and behavioral health challenges, which we all know, because on this call we're a veterans user group, we all know our veterans have unique and uniquely prevalent social determinants of health and mental health and behavioral health challenges. Our veterans have significant homelessness problems, significant poverty problems. Our veterans have significant depression and mental health conditions that are not the same as a healthy, wealthy, non-veterans Medicare Advantage traditional idea of MA. So again, as we imagine how to use these charts, we've been showing Kesley and the BeneLynk team how to help you all grab more charts for more purposes, some of which you can see on this slide, and all of which are vital to your STARS team's star ratings performance within the new needs of STARS. Kesley, before I flip to the next slide, let me take a quick pause. Kesley and I are going to do a little bit of bouncing back and forth so that she can weigh in with anything on the BeneLynk side that she wants to bring up with the user group, but before I go too quick to the next topic.
Yeah, no, that's great. Does anybody else want to weigh in? Don't be shy. Okay, we'll keep going, Melissa.
Okay, all right, so let's keep going. So we wanted to show you guys a couple of samples of sort of what's in the VA charts. Because again, a lot of us that are like operators and we've been doing this for a while, we kind of know the lists we give to a vendor like BeneLynk. We know what we expect out of it. We hand it off. We have built a lot of processes inside of our health plan space. And a lot of times we haven't looked inside the medical records in a really long time ourselves to know what we might find. So, so Kesley and the team, under all appropriate PHI protections, BAA protections, and NDA protections, handed over a sample of VA medical records to us so that we could take a look at the actual live content of the medical records that you all can use BeneLynk to obtain. And we just want to sort of show you guys what we could find if we began mining the quality and the care aspects in mass across the VA charts. Just take a look at some of what's in these records that are good for your teams to think about. We'll start from left to right on your slide. We know that while we struggle to get compliant blood pressure readings and A1C readings, sometimes the compliant values are sitting in that VA medical record. Our patients are generally not super nervous. When they go into the VA, they find the VA a comforting place to be, even though it's not really comforting for those of us that are overwhelmed by the chaos. Our veterans like to be among like-minded people. They like to be with nurses and doctors who really lean into them. That can really drive their blood pressure down while they're on the VA visit, where we can start mining CBP values. We can mine A1Cs. Again, our people are in the VA much more and more differently than they're often in the doctor's offices in our network, our traditional network. We also have a lot of undocumented preventive care and screens. sitting in the VA medical records right now. Again, a lot of you guys reached out and crafted your quality or HEDIS related work with BeneLynk around the hybrid samples of 411, which was small volume. Think about the fact that in 2024, the colorectal cancer screening measure holds us now accountable for every member's compliance with colorectal cancer screenings. That can be documented in unstructured notes where the patient has told a provider the date and results of their last compliance screening. It can be in the official data when they've had a screening in the VA. So again, if we think about how our veteran population is going to become compliant in 2024 on that measure as the first HEDIS preventive screening measure to flip to an ECDS logic model, that's going to be a really nice way of low cost, no new intervention, no waste to mine the information sitting in those VA charts for all of your members who have a veterans flag in the COB field and for whom you show as non-compliant on their colorectal cancer screening, and others as CMS goes down that path of putting more measures towards ECDS, not less. So I'm going to give a couple other examples, and then hopefully we'll have a couple of good questions and answers to talk through. So if I keep going across the row, again, it's really vital to remember how much your veteran population loves going to the VA. We've got a lot of medication reconciliations fully documented in those VA charts. The MedRecs for TRC-related visits, the transitions of care sub-indicator for medication reconciliation and a visit after a discharge from a qualifying admission. Those are fully there for the taking. Again, if I'm kind of shaping Kesley's world, our job has been to shape Kesley's and her team's thinking around how their services could port to new needs. These are great ways where you can chase the documentation for completed services without having to call the member for another appointment, without having to do a costly intervention. You can just simply mine the completed service information that's sitting in those VA charts. And then last but not least, I do want to talk a little bit about things that sit in Medicare Advantage on the survey measure side. Things like fall risk, things like monitoring physical activity, things like urinary incontinence or bladder leakage. Those are things that for us as Medicare Advantage plans, we often feel like we're an island among ourselves to solve. We feel like we need to be in the driver's seat of finding the intervention. But it's important to remember, for us to remember, that a lot of the information sitting in that VA chart that the VA focuses on for state-mandated Medicaid reasons are the same things we're chasing on Medicare Advantage for things like the HOS measures, for patient-reported outcomes measures like improving and maintaining physical and mental health that come back in 2024. These are the sorts of things that I don't know which among you in this amazing group of users, I don't know which of you are going to be that one party that wants to set a new bar and work on the full population of veterans as a cohort to mine this. But whomever raises their hand to work with Kesley and your account team, there's so much rich information in this batch of medical records that we can bring to life on the Medicare Advantage side that we think is great for Kesley and the team to bring to you guys today. Kesley, why don't I take a quick pause and we'll see if we have any questions before we go on.
Yeah, so as Melissa's kind of gone through all of this, I'm curious as to who's using more of the chart than just colonoscopies. That seems to be a good one. Who's actually like mining it for advanced directives or any of the other uses that she's kind of touched in here? The falls, the risk, social isolation and loneliness is a big one that we see in a lot of the veterans. A lot of them on the MA side don't ping often with some of the financial insecurities that we see, but that doesn't mean that they don't have other social determinants of health that are really impacting not only how they access care, but how they improve in that care, right? And we know that loneliness and social isolation can be a big one for them. Risk adjustment, we all good with that as I go across here? Okay, are y'all sharing your charts amongst everybody? Is there anybody that's only focusing on quality and not risk, or risk and not quality within your organization? Okay, I got one thumbs up so far.
I will say, Kelsey,
Okay.
we see that all the time. A lot of you guys who know me know that we've worked with at this point hundreds of contracts in MA. There's 800 contracts. I think at last count we've been in about 400 of them. We do see that all the time. If you're that person who's kind of like scared to raise your hand, you're scared to say you guys have been like buying VHRs or accessing VHRs for HEDIS and not getting it to risk, or buying for risk and struggling to get them fully mined for HEDIS. It happens all the time.
Yeah, member services is a good one. We purposely did not invite the big dog in MA to be on this call because we didn't want them to kind of overpower everybody. But member services, one of the things that they do is they put a little flag after everybody's name. They couldn't get IT to build another indicator, right? So they just put this US flag like emoji after everybody's name so that anybody, member services, care management, anybody can say and recognize that the person that they're speaking to is a veteran. And at the end of the call, the beginning of the call, whatever, thank them for their service. That goes a long way, right? This is a population that wants to be recognized. Who's done that in their organization, made sure that everybody knows that they're speaking to a veteran? Yay, somebody else with a thumbs up. And social care, is anybody planning on using the data in the medical record to do any type of community assistance outreach to try to solve for any of the documentation that's in there? Okay, that one I'm looking to have more conversations with. We've worked with Find Help to curate social care programs where the eligibility criteria is that you're a veteran, because veterans are more likely to accept help when they've earned it versus thinking that it's a handout, right? So we wanted to make sure that we had programs specific to their eligibility criteria, rewarding their veteran services for those programs, but still helping them overcome whatever their risk barriers were.
Yep. Okay. So Kelsey, I want to chime in with a couple of like super tips and tricks here. Because again, like we're a user group. The goal here is like that you guys get more juice out of your squeeze from all the services you're buying from BeneLynk. So a couple of really good tips and tricks on that front. I know this is a Veterans Link user call, but if you haven't checked out the community link services that Kesley and their team have built, it's best in breed. Best in breed on finding the programs that are discrete and concrete at the local area that a human being could literally find, access, and tap into for immediate assistance. Our team of experts across all of our domains has been amazed by that functionality. So pick up your phone and call your account manager for a run through of that. Again, Kelsey and Sean will tell you, we're all about promoting great skills and services, and that's a great, unique service that we've only ever been able to find here at BeneLynk. A couple of the things that we would point out, Kelsey can't possibly overstate enough for your veterans of thanking them for their service. Our veterans are really proud of what they've done. If you want to look at another couple of good models, take a look at the American Airlines model of thanking a veteran for their services. American Airlines loads their veterans first. They thank any flight where they've had an active veteran walk on and identify as an active veteran. They thank them over the PA system and do a round of applause. Those are the sorts of things that, as we imagine wrapping ourselves around the veteran population, if your veteran cohort makes up a large number of your measure needs on the stars and quality side, these are the things that start to pay back in a virtuous cycle. It's not an exact one-by-one relationship, but this is how you build your cultural community around this group of folks that matter. And then I'm going to give you one other example on the member services side that's a great illustration of what we're after. Think about what your members go to the VA for that are also on your Medicare Advantage priority list. They go for drug refills, they go for glasses, they go for hearing aids, they go for preventive care, and then they go for the things that your network doesn't let them chase easily. So all the specialty care that's hard or slow, they'll go sit outside on the front porch with their fellow veteran friends, and they'll wait hours and hours if they have to get an appointment weeks in advance of what they could get in our network. These are the sorts of things we want member services to understand. We don't want member services to be trying to overpoint them to our eyeglass benefit or our hearing aid benefit if they can run to the VA and get the $5,000 hearing aids versus our $500 hearing aid. We want them to use our benefits around and in tandem with what the VA gives them that may be better than what we could bake into our product. But you can see as I tell these stories, these are the kind of stories we probably, as we reimagine the new needs of STARS for veterans, we've got to work on training those advocates. We've got to figure out which of our member services reps are veteran experts, can have this conversation that's a little hard to script until we build the story for them. So again, lots of good ways to work around what you guys can do with and through your veteran presence and the BeneLynk teams.
Great. So we have a couple more slides that kind of pull this into the health equity index. And I know veteran status isn't currently one of those. I have a feeling, and I've seen some little lines here and there coming from CMS where they mention veteran status. Do you think that's going to be part of this one day?
All right, so let's talk about the Health Equity Index. The Health Equity Index is the single most important priority on every MA plan leader's mind right now, the single. So Kelsey and I felt like we had to talk about it a little bit. So as you guys know, right now it only takes into account dual status, LIS eligibility status, and disability status. You know, Kelsey, your question's complicated. The reason why CMS only uses those three identifiers of the current Health Equity Index population.
That's all they got.
That's all they got. That's exactly right. They kind of admitted their own limitations, which is kind of funny. That's all they have. That they have, literally, they have 100% of the data for 100% of the members, and they feel like they can anchor in. My guess is that we may see veteran status in the next 5 years added to the Health Equity Index. So again, timeline, let's think about what we're looking at. The first iteration of the Health Equity Index is going to use performance during 2024 and 2025. So we know they're not going to change that. We know the first year they're going to make the next wave of changes will be at the earliest plan year 26 or plan year 27. So we're a couple of years out before we think that they'll add veteran status into the Health Equity Index. But that doesn't mean, you know, again, back to real world application, that doesn't mean that we can't use our own internal data sets to layer our own Health Equity Index efforts and analyses with the veteran status as an indicator. We have the same thing with Native Americans who use the Indian Health Service. You know, within the Health Equity Index, all of that cohort where the federal interoperability doesn't pick up Indian Health Service activity, just like it doesn't pick up VA activity, is another black hole. So again, this will be, for those of you guys on the line, I'm looking at the list of plans that are sitting here on this call. This is going to be a plan-by-plan exercise of whether it's worth layering in veteran status to your own personal approach to Health Equity Index. Every plan will have a lens on that.
And I don't know if you've seen the kind of some of the latest coming out of the VA on the Cerner build, but you know, it's now up to a $50 billion build. They're trashing what they've already done. They're starting over, and the timeline is like 50 billion in the next 28 years or something ridiculous. So I don't think that there's going to be a good way to identify and to get these records in electronic format anytime soon, but yet it's still such a large population of people representing 22% of MA. So I think we need to keep an eye on it more and more.
Yeah, we know down to. And, you know, I'm glad you brought that up, Kesley, because like that's a really good example of the federal government not actually working in our favor to align this problem, despite 1 out of 5 of our Medicare beneficiaries being a veteran. So a couple things I would, really practical tips. For all of you on this call that are focused in the quality space, in the equity space, maybe not so much in the risk adjustment space because that side of the house has been pretty perfected from the veterans perspective, but anybody in the STARS space or the product space, this would be a great spot for you to build this into all of your feedback to CMS during Plan Preview 2, during the final ratings release. We'll have another final rule or 2 this year around quality, STARS, Medicare Advantage. You know, layer in your ask. CMS has to read every piece of feedback you provide. They have made every change to Medicare Advantage and star ratings quality specifically in response to a loud shared voice among users. So make your voice heard. If this impacts your plan meaningfully and materially, that their interoperability failures are impacting you, that their rules and requirements are impacting you, it's great to send them that feedback so that they can start building it into things like the Health Equity Index, things like how do they help us deal with these challenges instead of leaving all of us to fend for ourselves.
Yeah. So how do you think just the social risk factors of this population play into here?
Well, that's a really good question. So let's look at the social risk factors that CMS is going to be using going forward, measured by the SNS social needs screening ECDS HEDIS measure that is going on the display page for the moment. You know, the three areas CMS has prioritized is us asking if the member has lack of transportation, lack of stable housing, and lack of secure food source. Again, the truth is they know our veterans have a high degree of these needs. The more we ask, the more we resolve. The actual HEDIS measure will measure two activities. The HEDIS measure will measure the percentage of members for whom we perform a screening and the percentage of those members who answer negatively that we do an intervention with. This will be our true test of when we ask the question and we find a person, veteran or not, who has one of those three social risk factors, and we activate with an intervention like the community link interventions or other interventions, we measure it. It's going to be our true test of our moral imperative in Medicare Advantage. So a good time to, again, a really good time to think through what each plan's perspective is on this with veterans and non-veterans.
So keeping your crystal ball out for another minute, right?
Oh dear.
So we see this just in D-SNP right now, but in a lot of our managed Medicaid plans, there's state P4P that's almost the same type of measurement, right? The same type of requirements. When do you think this expands to all of MA?
Well, we thought it would already pass. So crystal balling, we actually thought that when CMS proposed adding a couple years ago, they proposed adding a requirement that MA non-SNP members would have the SNS measure as a new star measure. We thought that they would add it as quickly as they legally could because it makes such good sense. And because when a member has one of those three social risk factors, their medical spend is known to fall off the desirable trajectory. So there's a lot of reasons for them to put it on a star measure to disrupt the care cost continuum. So we're a little surprised they waited this long, but at the end of the day, this is a political animal, not a logical animal. And the big players, the second that CMS announced this, the big players flew their private jets in and they were grousing over how hard this would be to comply with. So I think, again, this is going to be a spot where CMS is using, in their words, not mine, they're using the free market forces of Medicare Advantage so that the plans who realize that the SNSE measure and doing the screening and interventions for social risk factors shouldn't be an after-the-fact reaction to adding it as a star measure. For any good plan who wants to make the maximum profit, they're going to realize they need to do it upstream, and CMS is going to watch the free market forces to play for a little while on this.
Yeah. Did you see the recent Elevance study? I thought that was really good, right? Where they looked, and if there was social risk factors, it definitely tied back to higher claims costs, higher comorbidities, and the ability to solve for those, and maybe not immediately bend that cost curve, but you have to intuitively believe that if you help these people overcome these barriers, they're going to live a healthier life.
Yeah, you're right. So again, back to crystal balling, the reality right now is that in Medicare Advantage, we're now up to of using Medicare Advantage as an instrument nationally to cover half of our Medicare beneficiaries in the nation, a full 50%. Now what we're seeing out of DC is every congressperson, every politician is leaning hard into their reelection bids because their constituents are 50% rolled in Medicare Advantage and they've got to protect their Medicare benefits. So what we're seeing right now is a wave of bills across the totality of Medicare and Medicare Advantage. You can look at all the things that CMS has put out for 2024 normal Medicare coverage. It's all about social risks. They're talking about paying hospitals more, risk-adjusted hospital payments for homeless members or homeless Medicare beneficiaries. So lots for us to pay attention to in the space of change, evolution, more evidence that gives us more oomph to lean into what our Medicare Advantage needs are and challenges are. And again, lots of new learnings for folks that are some are comfortable in the learning and the growth and the evolution mode, and not everybody is. A lot of Medicare Advantage staff and leaders have only ever known Medicare Advantage in the environment of stable rules, stable quality measures, stable regulations. So we've got a lot of personal growth, corporate growth happening alongside the political overhaul happening in DC too.
Okay, so the next slide is where I am willing to pay for opinions, right? I don't know what I'm willing to pay. I got some Amazon gift cards or something, but I really am curious. Melissa, can you lead a conversation on data aggregation, validation, and turning this all into a structured format?
Yes. Okay. So, one, I can't wait to hear what Kesley winds up having to pay for opinions, but I'm so excited that she has you guys to be her eyes and ears in the field. So again, remember why Kesley hired our team to come in and take a look. And Sean, Kesley and Sean wanted us to layer our eyeballs on the totality of what's happening across STARS quality integration of social, clinical, and risk adjustment. One of the things that we've recommended to the BeneLynk team is considering becoming a DAV certified vendor. So DAV stands for the Data Aggregation Validation Program from NCQA, whereby vendors can do the hard work on their side of getting NCQA approval and validation of their processes, of their data, and their outputs, so that vendors' customers can purchase the services and the data can be automatically loaded into the HEDIS engine without extensive supplemental data processes, PSV processes. Essentially, it puts the burden of NCQA authorization and approval as a HEDIS certified source of data on the vendor. We believe, as a lot of you guys know and have known me for years, we believe that what BeneLynk does is so differentiated that there is only one source to buy it from. There is nowhere else to go get VA data or VA charts en masse that we're aware of. So we've actually recommended that Sean and Kesley and the team explore becoming a DAV certified vendor so that those of you who are their customers can purchase more, not less, of their services, but process it far faster and far easier than you would have in the old world of grabbing a chart, putting a nurse mining the chart, figuring out what's in the chart, loading it into your supplemental data repository, and only then getting the HEDIS numerator for that one record. This would allow you to create the mass scale around your VA cohorting, back to those earlier uses that we started our talk with, the many uses of VA charts and the many quality related use cases that this could bring. So Kelsey, I hope that that's framed up the recommendation we made to you and Sean so that you can then sort of pick the brains of your colleagues here and get their take.
So I have no idea what it would cost to become DAV certified. But there obviously is some type of process and stuff. We are looking for your opinion. Is this something that would have enough value to you that you want us to explore it? I don't know how long it takes. I don't know anything about it yet, but really looking for some feedback as to what the value of this would be to all of you that are using this for quality and HEDIS and STARS. So anybody willing to raise their hand? Come off of mute. Yes.
This is Colleen, Blue Cross Blue Shield, South Carolina. So would this, maybe a question from Melissa, would this create a separate source that would need to be audited then by our HEDIS auditor?
So it creates a separate source that you have to pass through your audit prep, but it doesn't have to be fully audited because the vendor assuming the burden of being DAV certified means that you and your auditor don't have to go through that heavy, hard audit process, but rather you can use the DAV certification in lieu of that.
Okay.
Anybody else? Questions? So Melissa, would we also be abstracting the data into a structured format before it goes through that certification?
Yep, exactly. So, and you know, Kelsey, maybe so let me ask everybody to take a screen grab of this. Everybody's gotten really proficient with snip and grabs. Okay, everybody on, like, if all the users that are curious about this topic, grab a screen grab of this DAV visual real quick, and then I want to go back to a different slide so you can look at both pieces. Okay, so I'm going to give everybody like 5 more seconds to do a snip and grab, and then we're going to go back, if we could, to slide, I believe it's 8. Can we go back to the slide of all the, perfect, yep, thank you. So within the lens of what Kesley's trying to figure out is, would it be helpful if they were DAV certified so it would smooth the scaled path for you all to use their outputs as scaled HEDIS inputs? I do want to sort of remind everybody a couple of reality checks of what's coming that might shape your answer to her. Remember what CMS and NCQA have proposed around blood pressure and blood sugar. They've proposed that instead of looking only for the final reading of the year for the sample of 411 for those triple weighted measures, they'd like to move towards longitudinally measured blood pressure and blood sugar at scale. Again, I'm going to say it again because it's a mouthful. Longitudinally measured outcomes in HEDIS. So if you imagine, I want all of you guys to sort of be thinking through, if you've got your veteran population, might you need a different volume of veterans charts to get the longitudinal track record and have that set of values that line up to what CMS is proposing? Same thing for like diabetic eye exams. CMS proposed removing the hybrid measurement in 2024. Again, a lot of pushback, a lot of politics, a lot of politicking and lobbying. That did not, the hybrid methodology of eye exams did not get removed for 2024, but it will be removed. We just don't know how many years they'll fight the politics. So again, from the veterans' perspective, might you need all of those eye exams coming in the door en masse the second that CMS or NCQA pulls that hybrid thing out, hybrid measurement out? Same thing with flu. I'm going to give one more illustration, and then we'll go back to that question that Kesley's trying to harvest. You know, AHRQ and NCQA are in the process of retiring the CAPS-based flu survey measure and moving towards the absolute complicated all population measurement of the AIS vaccine suite. That is the multiple vaccines, including flu, measured by administrative data that can be loaded into HEDIS. So again, as we think through, like as Kesley and Sean are thinking through, do they want to pursue DAV certification? They're trying to figure out how you all are reading the tea leaves of how you all might be adapting to this top bucket in an ECDS environment with new and different bodies of all population quality measures that are not what we're chasing this year in the last year of the old. Okay, we can go back, Kesley, to that DAV slide, but I just wanted to sort of like put a little crystal ball thinking in everybody's head of what's coming down the pike.
So while the records are easily searchable, they're nice, clean records, I think most of this team that I've spoken to, right, you all are manually searching that. So you're opening up a record and you're looking for blood pressure, you're looking for blood sugar, you're looking for colonoscopy, you're looking for these keywords and then abstracting them one-on-one. So what Melissa is describing is you would get, before we'd still give you the medical record as your audit, but you'd also get an extract of all these different measures that were systematically pulled from that person's chart, and that structured data would come to you with this validation from NCQA already certified. Would you like jump at that? Would that be like, yay, I don't have to search all these records any longer? Okay.
Yeah, I would. I take the file over searching the record.
Okay. Thanks, Mackenzie. And Galeen? All right. Any other questions on this? How that would actually work? Okay. I thought this would be huge. I think you guys are going to noodle on it and get back to us.
Yep. Kesley, I really did too. And some of this, honestly, Kesley, this may be reflective of every organization is trying to figure out how they're going to evolve to an
Yeah.
ECDS HEDIS quality measurement environment. So maybe what I might offer is this is a good topic to put on a couple of these veteran user groups so people can go back home and do some homework and some searching so they can
Yeah.
figure out sort of what is their organization's plan to be 4 and 5 star level performers in an ECDS environment within whatever cohort they have of veterans. They may need to go back and do a little bit of homework to figure out if they're even ready to answer that as well.
Yeah, because what would that eliminate? That eliminates the need for your primary source verification when you're going through that audit process already, right? It's going to save you the time and the money for whoever within your organization is abstracting those that information, or that you're paying a vendor to do for you. And would you end up with like a CCD data stream?
You would end up with
Yeah.
a numerator compliant CCD data stream. All right, so I hate to do this to whoever's running the slides. I will owe you an apology,
Yeah.
and Kesley will owe you a gift card. Let's flip back up to slide 8 for a second, and
Yeah.
let's be honest about where we're going. If 1 out of 5 of our Medicare beneficiaries are veterans, if we imagine what we're going to be accountable for, we're going to just simply have to grasp we're about to be accountable for proving with numerator compliant evidence all of the eye exams, all of the BPs and A1Cs, all of the vaccinations, all of these things that we know by definition, our 1 out of 5 veterans are going intentionally to a VA clinical facility where we do not currently have line of sight to conduct. Eye exams are a great illustration. The second NCQA pulls hybrid measurement out of that measure, which will come, we're going to have to get all of the eye exam documentations, all of the flu shot documentations. There will not be the same kind of workarounds for small populations or undocumented evidence. And so again, some of this is going to be a lot of, I think maybe Kesley, a lot of back and forth between you guys and your user groups to decide this, because every plan's trying to figure out whether this is an impactful enough topic either to individual HEDIS measures or to the health equity index that it's top priority to tackle immediately, or whether they can tackle it next. So again, this could be like a one-on-one for your account managers, maybe need to be a one-on-one conversation that as people kind of build their paths.
So how about if for some of them that are in, we see huge variation for whatever reason, everybody in Minnesota that's a veteran goes to the VA, much higher rate, like 3 times as high rate as some other states that we have. If your population of utilization on the VA, maybe you are only going to get 3% of your overall membership is having a diabetic eye exam or a colonoscopy at the VA. How important is that incremental lift on each one of these measures if you get 3% of your population with a VA chart?
Do you have a Minnesota person on the line, or are you asking me, Kesley?
I'm asking you. I might have a Minnesota person on the line. Minnesota is probably much higher than that, but I am looking through the list. I'm not sure if I have a Minnesota person on the line.
So let's
anyways,
talk about that. Yeah. So let's talk about that. Let's just hypothetically say you've got 3% of your members in a VA facility, and you know that their colonoscopies were done at the VA or documented in an unstructured data field at the VA. The honest reality is, for most plans, every measure matters and every percentage point matters. CMS is doing everything they can to squish our ratings down and cause less QBP spend by having more plans under 4 stars than over 4 stars. I don't know a single executive that would say, don't worry about chasing 3% on a colonoscopy measure. Every executive I've been with would be telling that star leader, if you think you have a data source where the services are completed and all you got to do is administrative work to get the leakage, go get the leakage. Because the alternative, here's what the alternative is, and we'll just use this as a good illustration. The alternative is that on the MA plan side, you mail out a bunch of $15 fit kits and hope for the best that you're going to get somebody to poop in the box and send it back, or send out a bunch of $500 Cologuards that are going to drive up your cost. every plan is willing to stroke the check on mass mailings of FITs or mass mailings of Cologuards. This is an interesting alternative to say the documentation already exists. We're just going to spend the time and effort to build the data stream to collect it rather than drive the waste of the easy answer, which is throw out a bunch of test kits in the mail. So yeah, I mean, having been in plans, one of my plans one year was a 3.74, and we missed one phone call on one single weighted measure. It's hard to close your eyes to the easy stuff that's sitting in somebody's charts and say we can live without it at this point.
Got it.
Yeah.
Okay. Anything else you all want to talk about? Last chance to come off mute.
I have a quick question. If there was enough interest and you did move forward with a DAV, what do you think your turnaround time would be to be able to start that?
I really don't have a good answer for you yet. Happy
Okay,
to
that's
chat
okay.
about that off. We were really looking to get some feedback from you all as to how important it was. It's something that we are just starting to explore and looking for what that process entails, the timeline, the costs, everything that goes into it. But we literally just started, and this was part of that process.
Okay, thank you.
Sure.
And let me offer, you know, Kesley, as you're looking for feedback, I know, again, this is a veterans user group. Let me offer, as you all on this call are looking to get Kesley some feedback, remember the state of California is already using ECDS measurements for their ACA quality reporting. The state of California is already using it for all of their Medicaid quality reporting. Other states are fast follows. SNSE is already going to be tied into the ACA star rating as well. So Kesley, as you all are gathering feedback, it may be that this user group of veterans folks might be able to make a couple phone calls in their own plans and ask those other departments if the DAV certification of your HRA services and these other things might be helpful, again, as we silo bust outside of veterans into these other areas that need this service for similar reasons.
Good call. Okay. Well, I appreciate everybody's time. Thank you so much. And if you have any follow-up questions, here's Melissa's information. She's easy to find on LinkedIn as well. But there's her email. She'd love to hear from you, and all of us at BeneLynk thank you as well. Talk to you later.
Thank you guys. Yeah, thanks so much. So glad to be here and can't wait to see all of you guys change the veterans industry one plan at a time.
Great.
Great.
Bye,
Thank you
y'all.
all.
Thank you both.
Thank you.